Hi, I'm Kendra, and I will be presenting my research and intervention from this course for the management of cardiac arrest in a low-resourced rural hospital setting. My topic was chosen from working for an Indigenous-owned rural community hospital located on Treaty 4 territory where the clinical teams of physicians and nurses had interest in getting a mechanical CPR device in the hospital. Cardiac arrest is a medical emergency. In hospital, the code blue is often a stressful situation for the healthcare team involved. The Canadian Heart and Stroke Foundation provides evidence-informed clinical practice guidelines for the management of in-hospital cardiac arrest and highlight the chain of survival with high-quality chest compressions being priority. Studies have also found suboptimal chest compressions are provided due to fatigue and inconsistent rate and depth, and rural areas present additional challenges. So my work in this course sought to answer if the use of a mechanical CPR device are more effective than conventional manual CPR in the rural hospital setting. A search of the evidence was completed. Specific to my PICO question, I found 3 systematic reviews and 1 randomized control trial. It was a multi-center feasibility study conducted across 5 high-resourced UK hospitals over a period of 2 years. Overall, my research and appraisal found insufficient evidence to support mechanical CPR device use in the rural hospital setting, and based on these findings and strong clinical practice guidelines that recommend manual chest compressions are the standard of care, my work pivoted to identify an alternative plan of action. To address this gap of suboptimal chest compressions in a low-resource setting, a quality improvement program is the intervention I am presenting to you today. My secondary search of the evidence examined the traditional instructor-led delivery of CPR training and found skill retention diminishes as early as 3 months from the training, and often healthcare providers do not utilize those skills between instructor training. It results in further degradation and loss of confidence in skills. So the Resuscitation Quality Improvement Program was developed by the American Heart Association and recognized globally as a Mastery e-simulation learning module. The RQI system comprises a cart with an adult and infant mannequin equipped with built-in chest feedback, bag valve mask, and is connected to a laptop for real-time assessment and feedback. Learners are assessed based on compression and ventilation scores, and my intervention to introduce the RQI program to our rural hospital utilizes the Donabedian framework of structure, process, and outcome, and Lewin's change theory of unfreezing, introducing the new RQI program, and refreezing provides a theoretical framework that I have used to structure the implementation plan of the program. The desired outcome is adoption and sustainment of the RQI program to replace traditional CPR training. Benefits of the RQI program include high skill acquisition with a high frequency and low density approach to training. Learners are expected to complete quarterly e-simulation training, and it's self-directed and convenient to complete with real-time feedback that promotes immediate correction and improvement in skills. The program also provides analytical and benchmarking data on an individual and an organizational level. A crucial barrier to change in healthcare is a lack of awareness or knowledge of the current evidence or guidance supporting a change, or in this case, not supporting the change to implement mechanical CPR devices or a change in their practice. The other major challenge in the RQI program was identified as participant compliance, with that being dependent on the hospitals to monitor and enforce. So strategies to address the barriers are comprehensive at multi-levels and were guided by the trans-theoretical domains framework to support desired behavior change and acceptance of the new program. Overall, the program should be flexible and not rigid. The goal is to provide a safe, controlled, and non-judgmental environment for learners to develop confidence in their skills and performance. A mixed methods approach can be applied for evaluating this intervention through participant enrollment and compliance rates as well as their performance metrics. Pre and post test surveys can be obtained to gather feedback and satisfaction on the program from staff. And organizationally, a cost comparison and analysis can be completed between the RQI program and the resource and time-intensive model of traditional CPR training. Lastly, I've shared a list of resources used. Thank you for viewing my intervention. I'd be happy to answer any questions.